Welcome back, listeners. My guest today is Neil Braun. He is the Senior Director of Provincial Health Services Authority Allied Health Professional Practice. That's a long title, and I'm going to ask you what's involved in that. He was previously the Drug Diversion Lead for Fraser Health Authority, and it was while in this capacity that he wrote the now published article, Establishing a Multisectoral Collaborative Drug Diversion Program in a Canadian Health System. We're going to talk a little bit about the Canadian approach to drug diversion, and I think we're going to find that there are some similarities, but certainly a couple of differences too on the way Canada approaches things versus the way the US does. So welcome, Neil, to the podcast.
Thanks for having me, Terri.
We're going to learn a lot about your role as the diversion lead when we talk about your article. But for now, let's start by having you share, what do you do in your current role?
In my current role, I almost sort of explain it as a bit of a Price is Right example, is that you're trying to do as much as you can without going over. So it's really around, how are you leveraging the skills, abilities, and competencies of folks that we would say are allied health professionals? So looking for a simpler definition, folks that aren't physicians or nurses, so say social workers, occupational therapists. It's a list of 70 different professions and disciplines. How do you get them to work up to the full ability of their skills, their competencies, their training, and their knowledge without doing anything that exceeds what they're allowed to do based on legislation or regulation from professional, say, boards or colleges?
Okay, stay within really, their scope.
That's another way of putting it for the folks that are regulated, is exactly stay within their scope, but get them to work within the full range, work to the full limit of their abilities and their scope.
Sure. Yeah. Well, that sounds like a pretty interesting, diverse job. You've got to know a lot about a lot.
There's, as I say, there's 70 different disciplines that fall under that definition of allied health. And we as individuals only typically will come from one of them. So there's a lot of listening, a lot of connection, and a lot of working with folks who are experts in their field to do work that will do well by them and do well by the patients they serve.
Right. Okay. And your background is a pharmacist, correct?
I am a pharmacist. It's been some time since I've worked frontline, but that is my professional designation.
Yeah. Okay. All right. When we spoke earlier, you shared with me an event that happened in 2015, I believe it was, that kind of precipitated the start of conversations surrounding diversion mitigation in Canada. So I'd like you to start by sharing that with the listeners to give us that background.
Yeah, thanks, Terri. And that's what led me to that event, is what led me to my now previous role as a drug diversion lead. So in 2015, there was a tragic incident. There was a death of a healthcare aide that occurred in the emergency department of Vancouver General Hospital. So that's the biggest hospital in the province of British Columbia, which is on Canada's west coast. So in the city of Vancouver, that death happened as a result of this healthcare aide essentially emptying sharps containers from the emergency department, placing it in a suitcase, removing it from the emergency department, and then self-administering any syringes that still had some medication in them. And in almost all of those cases, that medication would be an opioid or controlled substance. But she passed away as a result of injecting rocuronium, which is a paralytic. So she essentially has a very tragic circumstance. This all became public because there was a coroner's report in doing an investigation into this death that found what the circumstances of it were. And her, the family of the person who passed away, they reached out to media in the Vancouver area, and there were a series of articles in the local newspaper here that published on this person and the circumstances leading up to her death, that she was experiencing substance use disorder, had gone for treatment a couple of times, and it was known that this was a challenge. This was a struggle for her by her colleagues in the time leading up to her death. So that led to then some more discussions from both within the health system where she passed away, but also the provincial government here in British Columbia that has some level of, because they fund the hospitals and acute services in this province, that gives them some degree of leverage in terms of directing the health systems here to take certain actions. So that led to them taking some of that initiative to ask the health systems here to do more around preventing and mitigating drug diversion from happening in our health system, and that led to the role of drug diversion lead getting created. And I was the first person to take that role in this province. Would have been in 2017.
Okay. So prior to that time, how was diversion mitigation or monitoring handled, or was it at all? Was it just kind of one of those things that nobody really thought about it?
I think it was a very ad hoc method of handling it. Is that depending on which hospital within the province it happened, which unit it happened, what the relationships say were between, say, the operations leaders on a particular unit that might have encountered drug diversion, what the relationships say were to their human resources counterparts or their risk or legal counterparts or potentially professional practice counterparts, who they would have then engaged in terms of doing work on whatever was observed or seen. And so you would have a very varied response in terms of how drug diversion was dealt with. It was a very, very ad hoc thing, would very much depend on the individuals involved in either investigating or looking into it. But there was nothing in terms of a consistent standard or transparent process that existed within our health systems here in this province before I came into the drug diversion lead role.
Yeah, that makes sense. I mean, very similar to what you would have in the US. Then it kind of depends on what has happened at your facility, right? If you've become aware that you have a problem, probably because of an event. I mean, I think that's what a lot of it. And then as the person with experience with an event goes to some other location, then it's like, hey, we got to look for this here because it definitely happens. So with Canada's healthcare system being publicly funded and a universal system, after this event in 2015 and then rolling into a couple years later when things are kind of getting up and running, does that mean that every facility started and was mandated to do the same thing? Or how did it work then with a diversion program implementation?
What I'm aware of is that following that death is that there was communication from what's called here a Ministry of Health. So it'd be the same as like a Department of Health for the province, to the different health systems that operate the hospitals and other healthcare, publicly funded healthcare services in mostly within the geographical regions of this province, to essentially say that more needed to be done to prevent or mitigate circumstances like what happened with the individual from happening again. So there was a little bit of guidance around, I think there was initial focus at that time around destroying pharmaceutical waste, because that's how this person passed away. But the different health systems receiving that communication in that direction from the Ministry of Health, I think they then took slightly different approaches in terms of what they wanted to lean into in terms of preventing or mitigating drug diversion from happening. And with the role I had, I was essentially supporting 4 different health systems, primarily based within the Metro Vancouver area. That's where they made the decision that they wanted to lean in and create this drug diversion lead role. And so I was the first, to my knowledge, the first drug diversion lead in this province. But I didn't stay that way, even though I was created in 2017. Other regional health systems within this province created also their drug diversion lead roles as well. So by the time I left the role around a year ago, all but one health system in this province had drug diversion leads. So it wasn't, I don't think it was officially mandated from the province to create these drug diversion lead roles, but these health systems, seeing some of the direction that was coming and recognizing the issue and the scope of the challenges, and then seeing some of the work potentially that I and others in the area the regional area I was working in had some success in doing the work that we were doing, took that as a sign or as an indication that they could create similar roles as well.
Sure. Okay. So walk us through the program then that you were a part of launching, and how much of that was your own research and what you had thought would work well and what could be implemented versus maybe what they told you. If it was just the waste part that they told you, the rest they left up to you to kind of figure out and learn on the fly. Walk us through that.
It was a lot of learning on the fly looking back at
Mhm.
it. There was certainly that focus around pharmaceutical waste, but I think there was a recognition from, from myself and from my leaders that we needed to think a little bit bigger picture around this. So we always
Sure.
focused around this notion around thinking about the work in sort of three buckets, that there's detection, so identifying that signs of drug diversion are being observed or being identified through auditing or other means. Investigation, so once signs of diversion are identified, what is our consistent, standard, transparent process for then looking into investigating those signs, or doing any of the responses that we would need to do to make sure we're aligning with legislation, with regulation, with any other needs that there may be. And then mitigation. So what are we learning as a result of doing those investigations? What do we think potentially could be put in place to mitigate future instances of whatever
Mhm.
signs of diversion that we investigated from occurring again? Uh, and I think just over the years then of me being in the role was then establishing, well, what could we do around each of those three buckets? And so what we eventually set up was using some, what's I think commonly referred to as first generation drug diversion detection software. So this would be software that pulls data from automated dispensing cabinets and tries to apply a little bit of an algorithm to give some sense about staff individuals that may be withdrawing more of a particular controlled substance than their peers. So there was, again, some trial and error in terms of taking what that software would generate in terms of data to then work with that to see, well, who do we want to spend some time looking into to see if there may be signs of diversion. There might be something going on here that's not explained by just uh, general practice, or say specific or unique patients that those staff may have been serving. So there was work done to set up how would we go about using that software. There was then work around setting up what are our policies and protocols for doing investigations. So who would we engage in terms of doing an investigation? What would be the roles and responsibilities of different members in conducting an investigation? How do we leverage, say, collective union agreements with staff in terms of how we can investigate staff while making sure they're being provided whatever resources or rights according to the collective agreement. And then mitigation, so making sure that we had an oversight committee made up of fairly senior leaders within some different departments, to say nursing, professional practice, pharmacy, risk, security, to make sure that whatever we were finding in investigations, we were then saying, well, what system level improvements or changes would we make to hopefully mitigate what we've seen happen in particular investigations from occurring again. So making sure that we had leadership on board to make those systemic changes that would need to happen. And that,
Right.
again, was all done over the course of, again, kind of a constant quality improvement
Mhm.
process of reviewing and refining and improving the processes that we have. And so that was done over a few years, and was also done, as I say, in the role I had. I served four different health systems here in the province. So it was really starting in the Fraser Health Authority, which is the published article really talks about their experience, but then taking it to the other three health systems as well, and establishing those same processes in those health systems.
Okay. So serving four locations, how did that work with using that first generation software, which really is a very manual, I mean, it kind of tells you where to look, right? But then the review itself is extremely manual. What was the process for that? Did you have
It was
help?
it was extremely manual, and I was essentially a team of one in my role serving these four health systems. And I think what at least worked in my favor was that we and I did not try to implement that software in terms of using it in all four health systems all at once. I mean, we're talking around maybe 24 acute care hospitals that I would be serving on my own, which I don't think is possible. So we at least had the chance to work with just a few hospitals in the Fraser Health Authority to start, and then again refining the processes before then spreading and sharing and getting more hospitals to use it. But essentially, the process that we laid out was it was sort of a 4-step process that would happen over a 4-month period, where the software would generate reports at the start of whatever month. I would send these reports to a contact at each hospital. So these reports would run for groupings of units within a particular hospital. The reports would get sent by me to particularly somebody with a nursing background at each hospital, so that they would know their hospital, they would know kind of the practice that different units would be doing within their hospital, and would also have maybe a sense too about maybe some of the individuals and some of the roles, so that if they could see somebody on a report who is withdrawing more of a particular controlled substance than their peers, they might have a sense about, is this person, say, a leader who should only be withdrawing a particular controlled substance once or twice in a few months, or somebody who you would expect to be withdrawing more often. What they would then do is they would flag, from reviewing those reports, flag a few names to a maximum of, say, 5, who they wanted to potentially review a little bit more deeply, do a deeper dive into. At which point, I would then take data directly out of the software, put it into Excel, do some cleaning on it to suggest, well, here's the patient charts associated with that staff that you've identified. Here's maybe some patient charts you want to review to get a bit of a clear picture in terms of whether there might be some anomalous activity or withdrawals happening that aren't explained by normal practice. Those contacts at each hospital would then review those patient charts to see, again, are we seeing patterns here, or other things that are concerning, say that there's not documentation in a medication administration record, that any charting data doesn't reflect that there should have been withdrawals, so say there's no pain assessments done, or something of that nature. And then looking for a pattern over time. So if we're seeing the same pattern over multiple patient charts, that again would be an indication that we have something that's not being explained by regular practice, and that potentially there would be a need for a drug diversion investigation.
Yeah. So really a collaborative event, or you started it, you made them pick, you got to pick somebody, and then you did a little bit more digging and then turned it back to them for a little bit more. Very collaborative. I want to know, did you ever do what I did one time? And that is spend hours and hours on looking at somebody's activity. And the very, very last transaction I saw in this manual review was a discrepancy where it looked like they took out, 20, but it was really only 2 or something. And it was just a discrepancy. It's like, oh my gosh, I just spent hours on this audit for nothing because there was something that explained the numbers.
And that shows the weakness of, or the weakness of, say, that first generation software. Is you just see the aggregate amount that's withdrawn of a particular controlled substance over a period of time. And we were doing these audits over 4-month cycles. And you're right, I would have exactly that scenario where a hospital would flag, whatever number of people. I would look at one and I would see that almost all of their withdrawal, all of the quantity withdrawn was just on one patient one time. Yeah. And when you looked, you saw it's like, oh, there was this withdrawal for this large amount. And then it was almost all of it was reversed or wasted right away. Right. And so I would say, to my counterparts at a hospital, well, you're probably going to want to just validate just by looking at this chart, but I'm pretty sure I know what you're going to find in that. This is all explained by just regular behavior, and that drug diversion is not occurring. But yes, it very much speaks to the challenge of that first generation software and finding those type of scenarios.
I never made that mistake again. From that point on, I checked every single one very quickly to make sure it wasn't a discrepancy. It's like, okay, not going to make that mistake again. That was, very frustrating.
Waste of time.
Yeah, absolutely. How did you go about getting your nursing counterparts, for the most part, up to speed on taking this seriously and what it is that they're supposed to look for? Because that's what we typically find, right? The people in the nursing roles, unless they're dedicated to this kind of position, they don't necessarily know what they're looking for. They certainly don't have the time to devote to looking for it. So how did you get that collaboration going and get that training done?
It's interesting. I think my experience may not be that much different than other colleagues working in other facilities across North America. Is that this isn't sort of an overnight thing where a program is launched, there's full buy-in from all the different sectors within a health system, and you're off to the races. I've heard people talk around in terms of building their programs that this is something that takes years to get that full buy-in from all the different teams that need to be involved. And I was certainly no different. In starting this work, it was very much localized to just a couple of units in a couple of hospitals, seeing what was possible, showing to people what the value and the potential of the work. And really, in a lot of cases, I can think of actually one of the different health systems outside of the Fraser Health Authority, when we first took this work to them and said, well, let's sit down with these audit reports and let's just look at them together so you can get a sense in terms of what the software can show you. And right there, you can see, very, very plainly that somebody is doing something very different than their peers. And so I said, well, again, we haven't done the chart review work or any of that deeper dive yet, but
let's start with this one.
Let's start with this one. And when I'm wondering if we might find something, knowing full well that having some experience looking at the reports, that I'm pretty sure this person is diverting. And then when they go through that process and say, oh, I didn't have any idea that diversion was happening in my hospital or in my unit. You've then got that buy-in from your nursing colleagues for a very long time afterwards. And once you just, again, kind of build the sustained and regular process of doing the work and find whether it's more diversion or other bad practice that gets identified just as a consequence of doing this work, you kind of reaffirm and reestablish the value that this work has on multiple levels. So I guess my wisdom that I learned through this is that, buy-in doesn't happen immediately or overnight, but once you get your hooks into folks, they will see it, and they will also spread and share to their colleagues as well. Say if you have a health system with multiple sites or multiple hospitals, those people talk to each other. So if one person is seeing it in one area, they will let their colleagues know, and that will also help you as you spread and share the work around mitigating diversion.
Right. Yeah. And so this is probably a good point. Share with us some of your numbers. When you started your program, did you find people right away?
Yeah. And that's something that's mentioned in the article, is that to the best of our knowledge, there was only one confirmed instance of drug diversion that had happened in the Fraser Health Authority. And so we were talking about a region that has 12 or 13 acute care hospitals. It serves a little under, I believe the number was a little bit under 2 million people living within that region. So this is not a small area, but they were only able to confirm one instance of diversion and only did that one investigation the year before this program started in full flight. So 2018, only one case identified. The first year that I started doing this work with the Fraser Health Authority in 2019, there was 13 investigations into drug diversion that were started. And 8 of those 13 came back with a finding of yes, diversion. We substantiated that diversion had occurred. So it's very much, I would always use the analogy of like, if you lift up a rock and shine a light underneath, you'll be surprised at what you find underneath it. And I think if there's a health system that's not actively looking and doing that detection work, they're always surprised then when they start what they do find. That's yes, diversion very much. We think of maybe diversion is happening somewhere else, or it's a problem in general, but not for us in particular. Drug diversion is happening in all of our hospitals and health systems, and it does need that conscious and active monitoring to detect it. It's not going to be something that just you identify always by happenstance. It happens by doing the work.
Yeah, definitely. And if someplace doesn't have any kind of process to look for it, people know that. The people that have the substance use disorder, they know that. And so nobody's looking, and they take advantage of that wherever they can. So you're right. So those are some pretty some pretty interesting numbers that you find. And that is a lesson for everybody that's not looking at all or doing anything to mitigate. Those are probably the kind of numbers that you're going to find depending on how big your facility is and your health system is. What does a formal investigation look like, or what did it look like when you were with the program?
So one of the processes that we put in place was that, again, because this needed to be multisectoral, needed to be collaborative, we needed to have buy-in from the teams that were directly impacted as a result of observing or identifying signs of drug diversion. So essentially, there would be, in most cases, a conversation I'd be having with the manager of the patient care area or the unit where the signs of diversion were emerging from, to say, well, based on this, what do we think do we think that drug diversion is a possibility? Not to say it's confirmed, because you do an investigation to investigate to make a conclusion, but just to say, is it a possibility based on the evidence we have in front of us already? If they say yes, I would say, again, using our policy and our protocol documents that were created, to say, great, we have a process for investigating and actually looking into making determinations as to what happened. So with the support of the unit manager, I would then communicate out to the senior leaders of the unit that was involved, to pharmacy, to professional practice. In most cases, investigations involve nursing, so it'd be to nursing professional practice, to HR, to risk, and to security. And then there'd be reps from all 6 of those teams that would then come together as part of an investigation team that I would chair. And with those folks together, we would start to essentially make decisions about, well, what are the steps we need to take now based on what are the actions or steps we need to take now based on the evidence that we have, and then what additional investigating or digging to get more information, what steps would we have to take? And in most cases, the folks that are in this group, they're sort of responsible for their own areas. So it's not that we necessarily collectively be saying, yes, this is the steps we need to take, although there would be that guidance. It would essentially be, say, HR would be like, well, if you're telling me that somebody is taking out a whole bunch of a particular controlled substance and there's no documentation to support them doing that, that's sign that we could have a risk to the organization and to the patients that we serve. So per the collective agreement, that means I have grounds to remove this particular staff member from service pending an investigation. So they would take the lead in terms of doing those actions from an HR perspective that they would need to do. If we did have, say, again, unaccounted for controlled substance that we're not sure what had happened to it, similar to the US, Canada has legislation to say, if you have losses of controlled substance, you need to report it to the federal government. So pharmacy typically would take the lead in terms of making those reports. So it'd be that kind of, and there'd be other examples of other steps that we'd take in the immediate term. But then we'd also then decide, well, what additional evidence do we need to do, or do we need to collect to get some sense about whether we can substantiate if drug diversion occurred? In a lot of cases, this would be supporting doing an interview with the staff that we'd associated with the signs of diversion. So that may mean doing additional chart reviews, additional audits of transactions on automated dispensing cabinets. But a lot then that evidence would then set up for the manager of the unit and a representative from the HR team to do an interview with the staff. And typically through that process, we would get some sense, in many cases, we would get some sense about, say, the person may admit to diversion and say they had a substance use issue, which would then lead them towards a treatment pathway. They may offer an alternate explanation, which we may deem as credible based on the evidence that they provide or the explanation they provide, or we may deem as not credible, and that would then necessitate some other actions as well. But we typically make a point of having a clinical person in that interview space so that they could then hear what the person we identify with the signs of diversion is saying, and assess whether what they're saying is actually credible from a clinical, from an operations perspective.
Sure.
And then through all those processes at the end, once we either substantiated or not substantiated diversion has occurred, the team would come back together, run through its findings, and create recommendations around how could we potentially mitigate what we've seen happen here from happening in this particular unit, in this particular site, and potentially even across the health system.
Mm-hmm. Okay. Is a drug screen usually part of the investigation?
No. And I think that has to do with legislation and collective agreements in Canada. So I know that this is something that's used in some jurisdictions in the US, but it's not something we ever used in this country.
Okay. And is it the HR representative that typically leads the interview portion of it?
They do. And again, that's also looking both from an investigation perspective in terms of doing an interview with the person, but also knowing too what the collective agreement, what the processes that are stipulated there. So they'll be kind of the experts in that, and we'll also be the experts too in terms of process for conducting an interview. But they're doing this in collaboration again with the unit manager to make sure that that unit manager can provide the context in terms of how practice operates on that particular unit, what other staff may be doing as common practice on that unit. So it's very much a collaboration between those two folks as being kind of the experts and closest to the unit and to the practice.
Sure. Yeah. When a union or collective agreement, is that what you call it? Collective agreement is involved. There's a lot more rules that
There
go with that.
There is, and there's also if there's a medical issue that's leading to the behavior that's being observed. So in that some cases, how investigations would end is that the staff would essentially say they're not fit to attend an interview because of a medical issue, and then as medical information is submitted through the following processes to establish that yes, this person has a medical issue. If there's what's called a medical nexus, if there's a medical nexus from explaining behaviors that are conducted in the workplace, i.e., a person is experiencing substance use disorder, which is leading them to divert controlled substances, we would take that also as evidence to say that diversion has occurred. And so that way, we're trying to provide every opportunity for to get a staff's perspective in terms of what we're seeing in our side of the table in terms of evidence. So. And that can come in an interview, but it can also come through this sort of secondary medical information that can support us to make a conclusion about whether diversion occurred or not.
Okay. And then is it typical whether they said I have an underlying medical condition that ends up being substance use disorder, or they just admit, yes, is it the goal then to get them into some sort of a recovery program?
And that's very much it. And that's where it starts to transition a little bit from decision making with the actual staff to HR and to disability management. And they then again would apply the collective agreement with the union in terms of how they can or can't proceed. But we typically say, as a matter of course, is that we make the organization would make every effort where possible to support treatment and recovery for individuals identified as having substance use disorder. Certainly, there'll be other factors too. Every case is individual and unique. So certainly, there's going to be decisions made on a case-by-case basis as to whether treatment and recovery is the appropriate course for that employee. But as a general principle, I think that's the outcome that we'd all like to see, is that people that are struggling with a medical issue are given the opportunity to get well.
Okay. And is there any government stance on reentry back into work, or is that facility dependent? Is it allowed, never allowed?
And that's part of where the professional practice role in these investigations comes in, is that if you're say it is a nurse who's diverted and is experiencing substance use disorder, regardless of the reasons for the diversion, if there's signs of diversion that are observed, that needs to be reported to the regulatory body. So say in the US, you call them, say, the nursing board or pharmacy board. In this country, regulatory college is more the common term. But typically we would, once we have evidence to suggest that it's like this person has withdrawn controlled substances without proper documentation or an order or something of that nature, it would get reported to, say if it's a nurse, to the nursing college here. They would then have it within their purview to say, this person can't work. Their nursing license is suspended until we can do an investigation. So certainly, depending on the gravity of the evidence that's been shared with them, they'll make their decision according to that evidence to say whether this person can work, whether their license is suspended, what have you. But as then they do their investigation, and certainly they'll ask us to share what information we're finding out, they'll then make their decisions in terms of like when and how this person can come back to practice. So typically, if this is someone who has diverted because they're experiencing substance use disorder, they'll typically say this person can't work as a nurse for X period of time. And then when they do come back, there'll be certain limits and conditions placed on their registration status. So say they either can't be working alone in an environment where they have access to controlled substances, or any of their transactions regarding controlled substances will need a co-signature from another registrant, things of those nature. And again, there'll be a period of time, again, case dependent, as to when those conditions will be in place. So it's trying to kind of bring a person back into doing their work, but also making sure that the public is protected from any risks that may be present.
Yeah, absolutely. So a lot of what we've talked about sounds very similar in the US and Canada, not a whole lot of differences. Is there something that you would say you have noticed is a difference between the way Canada handles something versus the US when it comes to a drug diversion program?
Yeah, there's two things that I think that are maybe I'll give an example of one that I could see is maybe is a pro and one is a con, although again, depending on your perspective as to whether you call them pros or cons. But one difference is, sitting in this country, I'll often see headlines coming from the US of, the DEA levies a multi-million-dollar fine against this health system, or maybe in exceptional cases that somebody is in a leadership position, potentially has even been jailed in some cases. In my time doing the drug diversion lead role in the Fraser Health Authority, I never once saw the equivalent body in Canada would be Health Canada. They would be the federal body that would be responsible for enforcing legislation around controlled substances. I never once heard a report of Health Canada levying a multi-million-dollar fine against the hospital. I never heard about other consequences or anything else of that nature levied by Health Canada. And certainly I had pretty limited communication with them in the role that I had. The most I would have is they would ask for clarification in terms of loss reports that I would submit to them. So whereas I see in the US that certainly one of the motivating factors for health systems in terms of leaning into the drug diversion work is compliance with federal enforcement. That's less so of an issue in this country. So that potentially creates some challenges in terms of getting more investment in terms of more capacity or resources. Where there may be a bit of an advantage in the Canadian health system is that with each province essentially funding its own health system for its entire province and having some degree of oversight or direction setting, is that when there are instances of drug diversion that get some attention from policymakers or the public, there is an opportunity for provincial governments to lean in and say to their health systems, you need to be doing more around this, or this is what in particular we want you to be doing around this. And so again, that's how in my province, that's how these drug diversion leads roles were set up as a result of provincial direction that hit the entire province's health system all at once. So it's not a case of different health systems having to have their own experience with drug diversion and deciding to lean into it and getting kind of a patchwork, say, across the country or even within states in terms of who's doing how much with regard to drug diversion.
Sure. Okay, yeah, that makes sense. Here we have ASHP, which you've probably, I'm guessing, had looked at those guidelines. Do you have something comparable in Canada that also gives you guidelines as to what to do with a program?
We do, and that's another point of actually divergence between the two countries that I've seen, is that with the ASHP guidelines around controlled substances management and drug diversion prevention that I believe was released at the end of 2022, it really does, you kind of see in terms of reading the article through, is that the focus at the start of the article or near the start is around detection and investigations, sort of this thought that drug diversion, because it's driven by substance use disorder, this is something that is going to just happen as a consequence of health systems having controlled substances. So yes, there is certainly, it has its focus in in the ASHP guidelines around control processes that might lead to it be more difficult to divert, or it might standing out a little bit more, but really putting that focus around detection and investigation. The Canadian Society of Hospital Pharmacists, so our ASHP equivalent, they last published their guidelines around drug diversion and controlled substances management in 2019, so about 5 years ago now. It's almost flipped. It's very much focused on the control processes. So basically, every step of the way from ordering a controlled substance to it being administered or wasted, how is that being accounted for, and how is the controlled substance being secured along all parts of the journey? Certainly, that's very important. Like, that's one side of the coin. But the focus in those guidelines on the detection and investigation pieces, I think it's limited to like 1 or 2 pages near the end of the guidelines. So it kind of suggests that I think there's an opportunity for, in this country at least, for us to be focusing on both sides of the coin. And that certainly we paid attention to one side of it, and certainly with other literature that's been published around drug diversion in Canada, again, focus on control processes. But I think there's an opportunity for us to be doing more in this country around the detection and investigation pieces.
Sure. Yeah. Because you can do everything you can to try to prevent it, to mitigate it, but people will continue to find ways around it because it's a disease that, desperation, right? They're going to, whatever they can try to do. Yeah. That makes
100%. Yeah.
Yeah. Yeah. Okay. And, oftentimes we find definitions mean something different to different people, and certainly maybe in different countries. When you talk about diversion in Canada, is it exactly what we talked about today, or does it have another meaning as well, if you mention that to healthcare professionals or the general population?
It's very interesting because up until I'd say about a year ago, if you were to use the term drug diversion in a clinical environment, or maybe even in the general public, I think a lot of people would be thinking around what we're talking about here, where you're talking about nurses, doctors, pharmacists, healthcare workers taking controlled substances when they don't have authorization to do so, and in a lot of cases taking it for their own personal use. In this country, the term drug diversion, especially in the public perception of it, has changed. That as there's been an expansion of what's sometimes in this country called safe supply or safer supply. So essentially, this is using other opioids, most commonly hydromorphone, as a medication, as opioid agonist treatment. So in addition to, say, methadone and Suboxone, is using opioids that we typically would prescribe for pain, using that to manage substance use disorder. That's attracted controversy in this country, in that there's concern that some of what's being prescribed, again, to mitigate a person's substance use disorder, is then patients that are receiving that are then turning around and then either selling or supplying it to other people who don't have authorization to take it. So in this case, we're talking about clients essentially receiving opioids and then diverting it to somebody else. So so in public discourse in this country, that has gotten a lot of attention, is using drug diversion to describe that scenario rather than talking about what's actually happening within the healthcare system. So in my article, it was pointed out sort of in the review process that we needed to specify very clearly we're talking about drug diversion within a Canadian healthcare system, and not outside of it.
Right. Did you say that hydromorphone is used in treatment for substance use disorder?
That's one of the medications that's being used specifically for that, and that's probably the most common one that's used in these new safer supply programs that have been established.
Okay. All right. Interesting. All right. Well, this is great, and I think it's pretty cool that you were involved in. I mean, this is a big change of making something more formal with a diversion program. And I think of course, this is where my passion is. So I think it's really cool that you got to be involved in something like that and starting that with the grassroots in the beginning. Thank you for sharing that with us and what your kind of journey was like in your article.
It's something. I started the role in, I think, mid 2017 and left by 2023, so at the end of 2023. So around 6 or so years in the role. And so it's, again, my words of wisdoms to folks that are maybe stepping into this journey or embarking on it is that it is a long journey, and it does take time to establish the buy-in and the awareness, and it doesn't come overnight, but it can happen, and it is important work to be doing. So for folks that are new into the role, you stick with it is the advice that I give.
Yeah, great advice. Makes a difference. It's an important program. Yeah. Well, thank you very much, Neil, for taking the time and sharing with us what you've done and what you've learned along the way.
Thanks so much, Terri. Glad to share it with you.
Thank you.